Okay, we are live.
Good morning. Since we're just a few minutes away from noon, this is the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. Thank you for everybody that's joining us. This is, it's going to be webinar number 52 or so that we're doing here during the COVID-19 pandemic. We've had some wonderful speakers that have been on the different weeks here. If you missed any of our webinars, please go to YouTube and go to Washington Academy of General Dentistry, and you'll be able to see those webinars. You will not be able to get CE credit. Unfortunately, we can't do that right now, but we're working on updating our website. So in the future, you'll be able to do on-demand CE through the Washington Academy of General Dentistry. And that will be hopefully something that we'll get up and running in the next couple of months here. We'd like to thank all our sponsors, Comet USA, Patterson Dental, the University of Washington School of Dentistry CE department is who you'll be receiving your CE credits through. Those CE credits will arrive in your inbox in the next 2-3 days, depending how they get to those. You'll have a PDF. Just put your name on that PDF. Save that for your records, just in case there's any misunderstanding or there's some CE credits that get missed down the road. If you are an AGD member, keep in mind, we will be submitting your CE credits directly to the Academy of General Dentistry, and that will show up on your transcript within 2 to 4 weeks. So they're really backed up in Chicago there, so don't expect it before that. You're seeing some flyers that go by here. Those a lot of those courses have already happened. We're just leaving those up so that you can see what is available on our YouTube site. If you go to washingtonagd.org, you'll be able to register for tomorrow's webinar, and that will be the last webinar that we know of in our series here of our Washington AGD Stay Home, Stay Healthy CE series. Like to thank our panelist, Dr. Gary Hayamoto, for running the chat features and giving you information throughout the webinars. We've been sitting here for weeks together. I appreciate everything he's done. Like to thank our executive director, Valerie Bartoli, for organizing these webinars, putting them together. Big thank you to our landlords, the International Brotherhood of Electrical Workers Local Union 77. They've helped us out with our rent, our lease there during this pandemic. We appreciate everything they've done. We have an educational center at CTAC here in Washington State, where we can host meetings where we can have up to 140 people in for lectures. We can probably do hands-on for 60 or 70. We have hand pieces, and we're all set up to do hands-on courses that way. But what's really exciting is we actually have 5 dental chairs, so we can actually do hands-on courses. And Dr. Yassin has his implantology continuum. It's implantology A to Z. And if that's of interest to you, we've got 240 hours of CE credit that you can obtain by signing up for that course. We also have our comprehensive hands-on orthodontic program with Dr. Bin Tran. And today, this will be part 5 of our implant study club hosted by Dr. Yassin, and his guest today is Dr. Brancheau. We appreciate him being here and sharing his knowledge. Just a reminder that everybody that's being a lecturer or presenter has donated their time. There's been no honorariums paid out, and that's the reason we could do this. Like you and in your practices, we are kind of a lockdown on our funds here at the WAGD. But it has been tremendous, the support that we've received. A big thank you goes to the Canadian Academy of Restorative Dentistry and Prosthodontics for their kind donation yesterday to support our efforts. They've been a fantastic partner. We'd like to thank the Arkansas Academy of General Dentistry for pushing these webinars out to their participants, their constituents. Last week, we had a wonderful program hosted by the International Academy of Nathology. Dr. Paul Hasegawa put that together. And then on Tuesday, Dr. Kenton Ross from the Arkansas AGD put together the speakers on the Tuesday. And then Thursday, thank you to Dr. Peter Thompson from the Canadian Academy of Restorative Dentistry and Prosthodontics for putting our speakers together on Thursday. I know some of the CARD-P members out there were interested in seeing those webinars again, and those are now uploaded to our YouTube site. The YouTube site is Washington Academy of General Dentistry. Remember to like, subscribe, and click the bell so you're notified on webinars as they're uploaded there. We had just a tremendous lecture yesterday morning by Dr. Marcus Trosch that did a wonderful walkthrough on what he's doing as a physician and a dentist in Germany with his PPE and seeing patients. You will want to watch that webinar. I can't encourage you to watch it strongly enough, and that's one you'll want to share with your staff members. Then Dr. Manu Karbash did a wonderful job in the afternoon going through all the questions from the previous week and trying to answer those to the best of our abilities. It's tough to do right now because here in Washington State, we're still waiting for a little bit of guidance. Yes, we understand that we're supposed to be able to go back and see patients on Tuesday. That's May 19th. But keep in mind, there is a Dental Quality Assurance Commission meeting on this Friday at 1:00 p.m. If you're interested in that meeting, check your emails or go to the Dental Quality Assurance Commission website and get signed in because they have a limit of 1,000 participants on that webinar only. So if you want to see that information firsthand, you'll have to get registered for that. You see some of the flyers going by with QR codes. Use those QR codes to register for upcoming events. Obviously, you're in this one right now, and your CE credit will be coming from the University of Washington School of Dentistry, and that will be arriving in the next 2 to 3 days. Tomorrow, Tyler Jones is going to be talking about employment law for your dental practice. That's a good one as we are moving back into practice. So get your questions ready, and we'll try and hit Mr. Jones there with as many questions as possible to clear up some confusion as we're going back in after this pandemic. I'd like to thank our sponsors, Comet USA, Patterson Dental, Canadian Academy of Restorative Dentistry and Prosthodontics, the International Brotherhood of Electrical Workers, Local 77. We'd like to thank the support of our student chapter, the University of Washington School of Dentistry, AGD student chapter. Thank you for your suggestions of speakers and sharing speakers that had been lined up on your program with us. A reminder, our Master Track program still has a few slots open. Our Master Track program features 4 sessions. Each session is 28 hours, and we've actually rolled back the tuition on that. So those of you that are interested in getting your fellowship or your master's in the Academy of General Dentistry, that is a tremendous way to do it. It's really been a nice program that Dr. Gary Hayamoto set up years ago. If you go into our Master Track program, you can achieve your master's in 5 years if you stick to the hands-on courses there in those sessions and also do your case presentations. Well, let's take a look at how many people we have in. Oh, good. We're just about halfway there. We're just past the hour. And Dr. Yassin, have you joined us? Let me see here.
Dr. Hess, Dr. Yassin is with us, but he's only able to join by phone. He's having a computer issue.
Oh, that
So-
is.
Hello, Dr. Hess. Can you hear
There
me?
he is.
Yes, yes. Great. Well, thank you.
Thank you so much. I guess you can't really see me. Is that true?
Yes, we actually can.
Yeah.
We
Oh,
can see you
perfect.
now.
Yeah.
Perfect. Dr. Hess, Dr. Brancheau, thank you so much for joining us today. And Dr. Hess has been doing a great job for the last several weeks. Dr. Brancheau is our guest today. Thank you for joining us, Dr. Brancheau. How are you doing?
Of course. Good to see you. How are you?
Good to see you, my friend. I've been trying to log into my computer since 11, but I'm just joining through my phone right now. So let's start this meeting. Welcome, everybody. Thank you for joining us in this part 5 of our Implant Study Club. This is the last part for this Stay Home, Stay Healthy series that we've been working with the Washington Academy of General Dentistry. It's been a great success. We covered a lot of topics, starting from clinical tips and tricks and some bone grafting, immediate implant placement. And now today we have Dr. Brancheau with us to cover the soft tissue management and implant dentistry. Dr. Brancheau is a periodontist, local here in Seattle area. We graduated together from the University of Washington, perio department. And he graduated also dental school here from the University of Washington. I know, Dr. Brancheau, you've just acquired your new office like probably 6 months ago. So congratulations. And I know it's tough times for everybody right now. So how's it going at your end?
Oh, pretty good. You know, at home today, but hopefully we'll be back next week.
Yeah, we hope so. We're just waiting for more direction to go. So anyhow, I'm not really able to reach to my PowerPoint so far. We're going to be talking today about soft tissue management and implant dentistry. It's a great topic. We discussed, me and Dr. Brancheau discussed a little bit connection between both the soft tissue and hard tissue in implant dentistry. So today he's going to be touching base in both ways because of the connection of preserving the soft tissue will result in preserving the hard tissue, the bone itself. So Dr. Brancheau, we're looking forward to see your lecture. I will moderate the question and answers. Feel free, guys, to just put your question and answer in the Q&A section, not on the chat. So we'll be able to moderate the question and answer. So it's all yours, Dr. Brancheau. You can share your screen right now, and looking forward to listen to your lecture.
Dr.
Okay.
Yassin, just before we get going, yes, thank you for mentioning that the questions. Will please put those in the Q&A, not in the chat section. We're not going to use the hands up feature either today unless Dr. Brancheau wants to do that specifically. And the other thing is on Friday, you have an all-day implant virtual seminar you're doing with our implant continuum. We're going to open that up for others to attend, but there is a fee to do that, and we're going to figure that out. We're going to see if we can get that onto the WashingtonAGD.org website here, hopefully before the end of the day. If not, we will probably just send out an email to everybody that's on this webinar so that you can sign up for that. Again, that is not part of our Washington Stay Home, Stay Healthy CE series. That's part of our implant continuum, and there will be a fee to attend and get CE credits for that. No, you can't attend it, and if you don't want CE credits, no, there is a fee to attend that. And thank you, Dr. Yassin, for opening that up, you know, with everybody being out of work and looking for CE credits. We appreciate that.
Absolutely.
And I'll mute myself, and thank you very much.
Thank you, Dr. Hess, for mentioning this. Actually, yes, this Friday is part of our clinical implantology from A to Z program, which is a full year program. This is module number 8. is going to be covering the full arch solutions and implant dentistry. As Dr. Hess mentioned, everybody's welcome. It's part of the program, so it's not free. It's not the part of the Stay Home, Stay Healthy series. Everybody's welcome to join. Dr. Brancheau, you can share your screen, and we're looking forward to see your lecture.
Okay. Can you hear me okay?
Looks great.
Got it?
Looks
Okay.
good.
All right. Well, thanks again, Dr. Yassin. Great seeing you, and Dr. Hess and the Academy of General Dentistry for hosting me today. We'll be talking about management of hard and soft tissue through preservation and enhancement as part of the Stay Home, Stay Healthy series. So I work here in Linwood. I have a practice, Linwood Periodontics and Implants. I opened about a year ago. So it's great to be part of this community here. And I went to school with Dr. Yassin. We're good friends. So thanks again. Went to the UW, graduated there 2012, and then did my master's in periodontics there as well. I'm a part of a few academies, the Academy of Periodontology and the International Society of Periodontal Plastic Surgeons, which is a group I joined a few years ago. And we talk about kind of innovative techniques in all aspects of periodontics, but mainly pertaining to periodontal plastic surgery, which we'll be talking today. And then my wife, Ashley, and my new baby, Ethan, who's about a year old now, that I'm pretty excited about. So today, talking about preserving the hard and soft tissue, we're talking about techniques of periodontal plastic surgery, which was kind of a term coined in '93 by P.D. Miller, who also has the classification system for gingival recession defects, if you're familiar with the Miller class 1, 2, and 3. So we're talking about correcting or eliminating anatomic, developmental, traumatic, and disease-induced defects of gingival bone. And how can we apply these principles to implantology? So the first thing we want to be considering is preventing bone and soft tissue loss, using minimally invasive surgical approaches whenever applicable, and augmenting or enhancing the bone and soft tissue when that's needed. And then also using tissue molding techniques or restorative techniques to kind of get us the rest of the way there. So in terms of guided bone and tissue regeneration, this was originally used for periodontal defects starting in the 80s, studies by Nyman and Lindy. And so they showed that new attachment around teeth is possible for periodontal defects using barrier membranes and combinations of FDBA or autogenous bone. And these studies have been corroborated numerous times for periodontal defects. And you can also apply these principles to implant dentistry. The main consideration being not getting those defects in the first place. So controlling etiologic factors that start those defects from forming, and then achieving stability through proper home care and maintenance. And so we need to do regeneration when applicable, but ideally we are preventing these defects from forming initially. And so when we have cases where implants are needing to be placed, but placed into deficient areas, we have techniques that are used to grow the bone around them, and this can be done simultaneously. So when I was at the UW, I did research with Dr. Sulky Hong, and so we looked at placing deep implants into areas of deficient bone and then grafting around them at the same time. And so this is kind of a way to achieve the regeneration while you place the implant to minimize the number of procedures and surgeries that are done. And consequently, you get a better soft tissue result the less times you are actually going in there and doing surgery. And this is just a re-entry showing you that the bone does grow around the implants. And so you're able to achieve true regeneration with barrier membranes and bone graft. And it doesn't necessarily matter which type of bone you use. We used autogenous for that, but you can use FDBA, you can use BioOs. There's not really sufficient evidence to support using one type of bone graft over the other. In terms of membranes, it's better to use resorbable in cases where you don't want to go back in. And so non-resorbables are generally there's more complications with those exposures, et cetera. So resorbable is better in certain circumstances. When we're talking about the soft tissue specifically, traditionally we're talking about root coverage procedures or enhancing the gingiva through free gingival grafts. And so the free gingival graft on the left, started in the 70s, and in the 80s they started doing connective tissue grafting, Langer and Langer and Peter Nordland. So the free gingival graft generally for teeth is for augmenting the zone of attached gingiva, releasing frenums, aiding in oral hygiene, adding stability, and things like that. It's not necessarily the best for aesthetics, but it's commonly used in the lower anterior. And then on the right, kind of the standard treatment for Miller 1-2 recession defects is connective tissue grafts, because you get the better aesthetic color match. And nowadays there is kind of a push for more minimally invasive techniques to cover roots and enhance the gingiva. And whether that's a tunneling technique, whether it's a pinhole technique, there's various ways to achieve that. But this is kind of showing what is kind of moving towards these days is minimally invasive surgical approaches that don't have a lot of flaps and try to blend in the tissue nicely. I worked with Dr. Nordland for about a year when I was in San Diego, and he's written some papers on covering Miller 1 and 2 defects with connective tissue grafts rather than class 5 restorations, because you get better color matching, better natural appearance, and stability of the tissue around the teeth. With the connective tissue graft, if you can kind of do this in a minimally invasive way rather than placing a class 5 restoration, which could potentially leak or lead to further recession. So just an example of periodontal plastic surgery around teeth. And so now we'll kind of transition into the implant realm. And the first concept we'll talk about is extraction and ridge preservation, and how this will improve the hard and the soft tissue outcomes for future implants. So circumstances where a tooth needs to be removed, and there's, it's non-restorable, and the patient is interested in an implant in the future. But these are cases where we can't place implants immediately. There's just not enough bone, and there's potentially a large infection. And so we're trying to set up the situation and the foundation for a future implant. And so this is a well, studied subject, and I just, quoted a couple of papers at the bottom there, but essentially what you get is better bone and soft tissue healing by using an extraction and ridge preservation procedure, so that later on, when you come to do your implant, you can do a flapless placement or something where you're not manipulating the tissue again, and get a better aesthetic result. And this is just an example of the technique that I use most commonly for molars. So it's kind of a minimally invasive flap technique where you are doing a full thickness flap, but not extending it much past the bone level, just to gain access to the roots. And you're sectioning the teeth or the crown off, and then you're doing a Y section of the roots and removing each one individually, followed by thorough degranulation and rinsing with sterile water or saline. And then, Dr. Yassin and Dr. Catafucci talked about their preferences with bone graft material. I use FDBA, but BioOs can also be used, or autogenous. It's just FDBA I've had a good track record with it, and it's readily available, rather than trying to get autogenous bone from somewhere else to fill a large socket like that. And then the membrane that I use for these posterior cases is the PTFE membrane, the cytoplast or cytosurge membrane, which is a hydrophobic barrier. And so what that will do is just repel water and blood and things that you don't want to contaminate your bone graft. and then forocytoplast sutures, which are also really clean and non-wicking. And so you get kind of a clean exterior around the bone graft, so that you'll get nice soft tissue healing. And what'll happen then is after a couple weeks, you take out the membrane, and then you'll get keratinized tissue that will cross the surface. And at that point, you kind of enhance the amount of keratinized tissue at the top, rather than, maybe trying to get primary closure or something like that, or using a resorbable membrane. Those tend to kind of get contaminated. So this is just my preferred way to do it. But then later you can see you can do a flapless implant surgery and just really simplify things down the road. This is just another example of that. Like I said, a fairly common technique for molars and teeth that can't be implanted immediately. And it also allows you to preserve the crest of bone so that you can, when you're near the maxillary sinus, you don't have to do a lateral window later. If anything, you can do an osteotome placement, or you can place potentially a shorter implant like an 8 millimeter to avoid a sinus lift altogether. So I think it's a good idea to try to preserve all that crestal bone and then have a more simplified implant placement later. And this is just an example of a couple restorations on the molars that were done with this technique. I think one or both of these is actually an immediate molar, which we're not really going to talk about today. That's a separate topic. But again, just kind of trying to be efficient with the surgeries so that you can get nice soft tissue healing, and regain the papilla, so you're not re-entering the site too many times and causing more interproximal attachment loss and things like that. So these are nice screw retained restorations that were done, so you can have good retrievability. So we'll kind of move forward to the anterior now, and talk about immediate implant placement and some of the contour grafting and restorative tissue molding techniques that are done, and temporization to achieve nice aesthetics and soft tissue profiles. Dr. Catafucci did a great lecture a couple weeks ago, and so he really covered this subject well. And so the gingival fibers around teeth, you have of main interest when we're doing the procedures for extraction are the dentogingival fibers. And we're not really considering the alveogingival or the dentoperiosteal fibers unless we're doing full thickness flaps. But for the incisions, we want to try to keep it just to the dentogingival fibers when we're doing these extractions. And on the right, you can kind of see the difference in the fibers around a tooth versus an implant. And so on a tooth, the gingival fibers are attaching perpendicular, and on an implant, they are arranged in a more parallel fashion. And so what this means is there's just not as tight of a seal around an implant as there would be on a tooth, and it's not quite as resilient. So it really does depend on the underlying bone to support that tissue. And if the tissue is thin, you're going to have more instances of recession and inflammation. And so it just kind of emphasizes the point that the soft tissue profile for implants really depends on both the position of the implant and the bone structure underneath for it to be stable. And Dr. Yassin, just let me know if I'm doing good on time and things like that. So if I need to.
Oh, that's fine. We already have some questions. So you're good in time, and take your time, explain whatever you want to go through.
Sure.
I'm on my computer right now, so I can back you up whenever you want to take a moment or discuss something. So no worries. Thank you, Dr. Brancheau.
Sure. Yeah, just interrupt if you need to. Mm-hmm. So talking about the biotype or phenotype of the tissue, this is a whole nother topic, but we'll kind of just classify things for now into thick and thin, and there's average biotypes too. But For the purposes of treatment considerations, we'll just worry about thicker or thinner biotype. The thicker biotype is more common in males, about 84%. And then on the right, you kind of have that thin scalloped biotype, which is about 33% of females. And so you just have a narrower band of gingiva, you have a triangular tooth form, and you have more susceptibility for recession, black triangles, and aesthetic consequences. And so when you're managing cases, you can kind of survey the biotype to determine how you might approach it. And so some studies say that you put a probe in the midfacial aspect, and if you can see it through the tissue, that indicates a thin biotype. But I think in reality, it's a little more nuanced than that. Conceptually, on a thick biotype, you're going to have less remodeling after a surgery, and you can get similar aesthetic results when you do buccal contour grafting with bone than if you also added a connective tissue graft to it. In a thin biotype, you might need to consider more connective tissue grafting in order to get the same result, because the risk for more delicate and unpredictable healing. So let's get into some cases now. I'll try to show as many as I can. So I put a bunch on here just for consideration. So here's one case of internal resorption that's asymptomatic, but it's rapidly progressing. And it's a good idea to take a cone beam, and this was taken courtesy of the endodontist. You can see it's kind of a through and through internal resorption defect that's non-restorable. And the CBCT, as we saw earlier with some of the other presentations, shows you the buccal plate thickness and the root position and the availability of bone and some other considerations for determining whether you want to do an immediate placement. And clinically, you can see the resorption defect is pretty large, and it's also invading into the soft tissue on number 9. And if we look at the biotype, this is a thin biotype. He's about a 30-year-old male, but he does have a thin biotype and kind of a triangular tooth form. So there's a little higher aesthetic risk. A couple studies that are referenced a lot are Tarnow in 2003 and Cosson in 2013, who talk about papilla fill. And what they found is that on adjacent implants, if you place adjacent implants, you're going to get a lot less papilla fill than if you have an implant with an adjacent tooth, or even an implant with a pontic. And so the key number to remember is about 5 millimeters. If you can get 5 millimeters from the crest of bone to the contact point, your papilla can get filled about 100% of the time. When the distance goes up to 6 millimeters, your papilla fill is only 56%. And so there's a steep drop. And so it's important to preserve as much of that crest of bone as you can, so you can get the papilla fill to go up to the contact point. And just to quote a couple other studies, we won't go too much into research, but the Araujo studies from 2005 to 2009 showed that bone loss and ridge resorption after you extract a tooth is inevitable, and you can't really stop it. You can only try to mitigate it through your socket preservation techniques or your immediate implant placement techniques. And so there's significant buccal plate resorption when a tooth is taken out. And so the key is to leave a gap space in the buccal and graft that with some kind of grafting material, whether it's FDBA or BioOS. Doesn't really make a difference, but that's going to prevent the excess remodeling and exposure of that implant surface. And it's also going to prevent some of those soft tissue changes and aesthetic consequences. So our steps here were pretty This is pretty, straightforward coordination of the case with the general dentist. So they take an impression for a flipper, and the lab delivers it on the day of surgery. And then 3 months of healing, we'll do a pre-restorative check and begin the temporization procedures. And depending on the patient and the dentist's choice, you can start doing some tissue molding and temporary crown techniques to mold that soft tissue. And after that, you'll have a final impression and crown delivery. And so this is the surgery. So again, we're trying to do a flapless placement, and we are doing an overfill of the bone graft around the healing abutment. In this case, I did not use a custom healing abutment. We'll show a couple of those. But the idea being that you're trying to, the apical position of that margin right now is it's too apical. And so we want it to actually move coronally. And so we're going to do that by just overstuffing the gap space with bone graft all the way to the healing abutment and allowing it to come down. And then we'll trim back the flipper to allow for that to come down. We don't want to push that flipper into the graft. Otherwise, it's never going to move coronally. And so, and we also use the Benix extraction system. I think you guys talked about this earlier, but basically it's a way to get teeth out without having to do flaps or bone removal of any kind. And so it's like a wine bottle opener that screws into the root canal space, and it will just atraumatically remove it. So this is the 2-week healing. You can see how the margin has moved coronally around that healing abutment, and the soft tissue profile is more or less unchanged. And then this patient actually did start the temporary phase, and I think he's completed the final restoration. Unfortunately, we're under quarantine, so I haven't been able to see him yet. So I've called him to see how he's doing. He says he's great, but I still need a final photo. But we will show some final photos here with some other cases. But that's just kind of a typical case with a normal protocol. This is an interesting one because it has an infection on it. And so there was some discussion of this in some other lectures. And so I wanted to show kind of a different variation of this. And so there's, it was a good debate on, whether you can place an implant in an infected site, how infected is, too infected. And so I think you just need to have enough bone. You need to have enough bone to house the implant, and you need to feel that the infection hasn't compromised too much of that bone so that, the implant is going to not have stability. And you also need to put them on antibiotics prior so you can reduce that infection a little bit. So this is just using a larger healing abutment because it's going to fit into that socket a little better. It's a wider socket, so we use a larger healing abutment. And then we'll place our bone graft and our membrane along the buccal. So we're kind of creating a new buccal plate, but it's all done flaplessly. Again, we don't want to move any of the papilla or gingival margins of the adjacent teeth. And so same thing, just with a membrane up the buccal and a larger healing abutment. And that's kind of our 2-week soft tissue result. And so you can see how the infection is completely resolved. And here's another case where you have a high smile line and a high aesthetic risk. He has good gingival contours. He has a thick biotype. And this time we're going to do an Essex impression. And we're going to use a custom healing abutment in this case because we really like the soft tissue profile as is. And so we just want to preserve that exactly how it is. So we take a cone beam, and we won't go into too much of the cone beam considerations, but it's a good idea to kind of plan out your your implant placement to make sure you have buccal plate, to make sure you have, you know, no other anatomic considerations, and that you have palatal bone to place this into, so you can communicate whether this is a screw retained or a cement retained restoration to the general dentist. And so again, we use the Benix extraction system to remove the root. And this is an example of one type of custom healing abutment. It's a peak abutment from Straumann. And so you just, this is more of a reductive approach. So you just use a burr to reduce the form of it until it's matching the socket contours. And then your Essex can get placed over the top. And that's the 2-week healing on the right of the Essex. And you can see on the X-ray of how the peak abutment kind of traps all of the bone graft inside. So it's kind of the dual zone technique, which I'll show later again. But this is a good way to do it without, again, there aren't any sutures or anything like that. So finally, we'll show one with the final crown. So this is just a number 9 that was fractured the gum line. Same approach, just with a standard abutment. And this is the final crown. So you can see how the final crown blends in nice to the adjacent teeth. And this was done by Dr. Brandon Ford. And he uses digital impression techniques, and they send for custom shades at the lab. And so you can get a nice shade match with the restoration. And so kind of our success criteria here for these is preservation or improvement of the apical gingival margin. So, you know, if we look at the top, that's looking pretty nice. So we want to just keep that exactly as is. And so that's kind of our first goal, is where is that apical margin? And so we want to keep that in line with the adjacent central. And the second criteria would be the preservation of the interproximal attachment and papilla. And this is the hardest one to change. And so we really just try to mitigate any loss. And so that's why we advocate for immediate placements whenever possible, because it's the hardest thing to gain back. Once you lose interproximal attachment, it's almost impossible to gain back, and you have to start doing some pretty creative molding techniques or papilla regeneration and something like that. But in general, it's just less predictable. So we try to preserve the papilla, and then the final is after the framework is done, it's a nice restoration. And so I think some of the CEREC options and the digital impressions that are being done are excellent. And we'll do one that has a little bit more bone loss on the buccal. So this is number 8, and it's splinted to number 9. You can see the bone loss on the buccal on the radiograph. Again, it's kind of a high aesthetic risk situation, but this is a thick biotype. And so we're gonna do the same kind of technique with the buccal contouring and a screw retained crown if possible. And this is how that looks. And again, we're using the Benix easy extract system. And there's a flipper that's delivered on the same day. And that's the 2-week follow-up. And so can you use a connective tissue graft on the buccal? Absolutely. And I think that's just a choice of the clinician, whether that's what they prefer or not. For me, for thick biotype cases, I generally don't, but it's not wrong to do so. On thin biotype cases, it might be a good idea to add additional connective tissue, but essentially what that overfill technique is going to do, and the Tarnow group, Dennis Tarnow, Stephen Chu, and Salama, and those guys, they have a lot of papers on this. It's going to enhance both your buccal bone profile and your keratinized tissue profile just by overfilling the graft material all the way to the healing abutment. And so that's the final restoration there. You can see the papilla are intact, the apical margin's intact, and then a new crown was done on number 8. or sorry, number 9. This is from Dr. Joanna Valentine. Did a great job with that. And Dr. Yassin knows her pretty well.
Well, absolutely. We work together. Yeah, she's an
Yeah,
amazing dentist.
awesome.
I think she's attending. So hello, Dr.
Perfect.
Valentine.
Well, all the credit there, all the credit for the nice restorations. Okay. So this is an example of something that is not a good immediate case. And so why is this not a good immediate case? Well, there's a lot of factors going on. There's large infections. There is subsequent loss of bone. You have adjacent maxillary incisors. There's poor plaque control, inflammation, and there's a large tooth form on number 9. And so there's too much going on here where to feel good about trying to put implants in right now. So what we have to do is kind of augment the bone and the soft tissue. And so for this, we're essentially trying to throw everything at it that we can. So we're taking the teeth out. Again, it's as flapless of a procedure as possible. And then placing FDBA, we're placing resorbable membranes. And then this time we're actually going to add connective tissue over the buccal because we're going to try to increase the amount of keratinized tissue as much as possible. And then adding a flipper over the top. And so later you can see we have enough bone width and volume. We have enough soft tissue volume to do our implants. And we can do this by a flapless approach. And those are the crowns. Again, they're fairly long, but that's kind of his tooth form. And he has a low smile line, so that's acceptable for him. But just looking at the soft tissue profile, you can see how that's been augmented on those sites. And then on the adjacent teeth is more or less the same with minimal remodeling, some remodeling, but trying to keep it to a minimum. Am I still doing good on time, Dr. Yassin?
Yes, absolutely. You're good on time. We're getting a lot of questions, so I'm trying just to keep up with the questions, and it's all yours. I'm enjoying it so far. Thank you.
Great. Okay. So here's an emergency situation. This is, kind of all we've been dealing with since the quarantine started. So this would be a case that you could do, but this was before that. But you have a very large infection, with pain and swelling, and there's no buccal plate. And so this is one where, you can't do an immediate again. And so you just have to try to mitigate the damage that's going on. So place them on antibiotics immediately, maybe come back a couple days later, if possible. If you have to do it then and there, that's fine. But just extracting the tooth, is probably not a good idea because you're going to have a very large buccal defect because there's no bone and the soft tissue is just going to cave in, and there's going to be a very large concavity. It's going to be very hard to recover from that. So what we do here is extract the tooth, again, no flaps, and then we pack it with FDBA, and we're going to add a resorbable membrane up the buccal and kind of create a wall, and then that's going to lay over the buccal, over the crustal, and over the top of that, we'll do a socket seal with a free gingival graft. And so that'll kind of contain everything and also allow for additional soft tissue growth, ideally. And this patient also has a fracture on number 9 crown. So they need another implant on 9, but there's a lot of reasons why you wouldn't do these at the same time, because you're going to likely lose more bone in between, and you kind of have to deal with the emergency first. So we kind of phased out this treatment, and there's a great book by Cohen, his Interdisciplinary Treatment Planning, where they show some anterior serial extraction cases where they do one then the other, and I think it's a good idea to do when you have 2 teeth that need to be addressed, but kind of one at a time so that you preserve the bone in between. And so this is just kind of moving on, showing the healing on number 8. So getting back some of that tissue health. So it looks nicer now. It's pink. It's thickened. And then being able to do the immediate implant on number 9 with a similar technique. And so just doing that and phasing out those treatments will probably get you a better result than doing one at a time. But the key being on the tooth that's really infected, trying to do some kind of augmentation at the time of the extraction so that you don't lose too much of the bone and the soft tissue. I just wanted to show a quick case with the custom healing abutments. And because I just love these crowns, they're amazing. So she loved these custom crowns that she got down in Olympia somewhere. But unfortunately, those teeth were fractured off. And I tried to reline these onto temporary healing abutments, but her occlusion just wouldn't allow it. I wasn't able to get it so that they were out of occlusion. And so unfortunately, but she took them home anyway as a souvenir. But it would have been nice to use these as temporaries, just because I liked them so much.
Nice crowns.
Yeah, they're great.
Yeah.
But I was just showing an example of the custom healing abutments. I know Dr. Catafucci and you guys already talked about this a little bit, but just it's another way to minimize soft tissue remodeling, especially if you have 2 adjacent implants that you're doing, that can preserve those contours nicely. Okay, and then this is kind of the next level of where things are going in terms of soft tissue management and provisionalization. And that's doing immediate provisionals. And so, like I was trying to do on the previous case, you have to make sure that there's no risk of bruxism or contact on that tooth. And so some patients, they just can't promise to not use it. They might forget and start manipulating that tooth sooner than they need to. And so I prefer to go no function at all for 6 weeks, preferably longer, to allow the implant, its proper integration period. But if you do want to do a provisional or immediate provisional, it does have some advantages in terms of aesthetics. So you can use the same crown to hollow out and attach a temporary healing abutment. And so you'll graft around that temporary healing abutment, and then you'll reline the crown form onto that temporary healing abutment. And so this is what it looks like on the day of surgery is on the left, and 2 weeks later is on the right. And you can see it preserves the tissues really well. And this is a screw retained access. So in case something gets loose, you're able to go in there and tighten it up. And so later on, you can, of that tissue form, you'll be able to take a custom impression of that tissue form, which should match. And I think the wave of the future here is going to, lab fabricated temporary crowns that can be installed on the same day as the procedure, and just transferred all the way to the final through digital planning and guided surgery. So I think this is kind of a hot topic at the perio meetings and where things are going. Finally, I just kind of wanted to tie all the methods together with this case. And so it involves soft tissue grafting, Pontic site development, and custom impression techniques. So you can see that custom impression technique in action. And so this is a combination case where you have ortho, pros, and perio. And the ortho and pros was the bulk of this. Getting to this stage took a number of years. So just getting there took a lot of planning, but once she's at this stage, she has congenitally missing 6, 7, 10, and 11. And they wanted to, and she has a high smile line, triangular tooth form, thin biotype. So there's a lot of challenges in terms of being able to get the soft tissue profile to where you want it aesthetically. And so the prosthodontic plan was to do cantilever pontics to the lateral sites. And so implants in 6 and 11, and then cantilever pontics. And this is based off those studies that are showing that you can get a bigger papilla fill from an implant to a pontic than with adjacent implants. Adjacent implants just probably wouldn't have the aesthetic result. Functionally better, but not the aesthetic result that you want. And so this is just some of the planning, a wax up and a cone beam guide. And so that allows us to plan out the surgery prior, so we know exactly what we're doing. And so the surgery does involve flaps this time because there are buccal concavities up the crest. And so those need to be grafted as we place the implants. So we're going to try to combine as much as we can into this surgery so we don't have to do multiple surgeries. But what happens is we're going to place the implants in the canine sites according to the guide, and then we'll graft over the concavity areas or the dehiscences with FDBA and a resorbable membrane. And this is, again, according to a lot of those studies and some of the research that I did that shows that the bone graft will adhere to that implant surface. And then for the pontic sites, we're going to place connective tissue. And this is either from the palate or from the retromolar area, as Mitch likes to do. So wherever you can find it. And so what this will do is just give the restorative dentist or the prosthodontist more flexibility and options for molding the tissue, because that's the challenge that they're gonna have to do. And so primary closure is the way to go here, so you can get all that bone and soft tissue to heal. And then 2 weeks later, that's the healing on the bottom, and they are just back into the orthodontic appliances while these implants are healing for 4 or 5 months. When it's ready for the next step, it looks more or less the same, and that's kind of what we were hoping for, is we don't have, any interproximal attachment loss showing root surfaces or scar tissue or things like that, because we do have to go in one more time. So this is our next surgery and final surgery, which is just the second stage. And so we're exposing the implants, we're placing healing abutments, and then we're layering some extra connective tissue around those pontic sites just to give as much bulk as possible. And now they are ready for temporaries. And so these temporaries are designed to push on the soft tissue. And you can see the blanching effect in those pontic sites. You can see how it's turned completely white. And so that's the idea, is that by pushing into those, it's going to start to mold it to the mesial and distal. So on the right side and the left side, you can see that some papilla is being created. Very difficult to get it all the way there, but you're at least making progress. And these are composite temporaries, so you can add and subtract to these as needed to push the tissue, or if it's too much, you can reduce. And so there's a little bit of play here to get it to where you want it. And typically 8 weeks in the temporaries is enough to kind of modify those sites and the papilla to get it to where it's almost ready to go. That is just the X-ray. And so this patient actually went the extra step. Dr. Bitsis, he's a great prosthodontist here in Seattle that Alan and I are friends with. Giannis, I've worked with him a lot, and he's he does great work. And so this is actually lab fabricated temporaries as a final step. And so you can see that the papilla is really nice on the right, but on the left, it's not quite there. But I think that's as far as it was going to go. So you can see how challenging that is to reproduce, but they got it pretty far along, so it's almost filling. And that's what that looks like intraorally. And so here's where the final impression technique comes in. And so the you can see those sites are molded, and now what Dr. Bitsis is doing is he is doing a custom impression technique. So he's taking those crowns on the lab analogs and then pouring a light body PVS around it to capture that profile. And then into the lab analogs goes the impression copings, and GC pattern resin is the red material you see there. And so you just take this custom impression coping and insert it back in, and then take a open tray impression of that. So you've captured the soft tissue profiles for the final restoration. So there's no further movement of the soft tissue when the finals are inserted. And so this is the final, and I think it looks great. Dr. Bitsis did an amazing job there. And so it's just kind of a combination of how the framework can be modified, and to get the rest of the way there, some of those temporaries and custom impression techniques can be really helpful to get a nice final result, especially for challenging aesthetic cases. And so that's just the side picture. And you can see she came quite a long way. So it's not just the prosthodontic work, but the orthodontic work too. And Blake Davis helped out with that. Orthodontist, a good friend of ours. And so that's all I have on the topic. It's a large topic, and there's plenty more to discuss. But so in summary, the hard and soft tissue preservation and enhancement strategies are important for successful outcomes for implants. And so it's really about preserving what you have, and if you can't preserve it, then trying to augment. And using minimally invasive and gentle and flapless techniques whenever it's possible. Ridge preservation should be performed anytime a patient is considering an implant in the future to mitigate the loss of bone and to optimize the implant placement and success. Immediate placement reduces the number of surgeries, treatment time, and cost, and can improve the aesthetic scores by preserving the natural tissue form. And ponic site and soft tissue grafting can be used as needed for biotype thickening and to enhance the appearance and stability of restorations. And then also the tissue molding techniques through the immediate provisionalization, custom abutments, and temporaries is also important. And interdisciplinary treatment planning. If you have any questions, my email's on there, brian@linwoodperio.com, or you can call or text me on my cell phone. And it was really fun. I hope everyone learned something and had a good time.
It's absolutely great. Thank you, Dr. Brancheau. Brian is my good friend, and I know you're a great clinician. We've been working together for a long time. So thank you for the great presentation. Yeah, we have a lot of questions. So if you're ready, we can just, we have all the time to answer questions, go into discussion. And doctors, if you have any other questions, I'm here to moderate the questions as well. Let me start with the big topic, Dr. Brancheau, talking about the PRF use, right? And a lot of questions came to just discuss the PRF use and the enhancement for the soft tissue. Any opinions about the PRF especially in the soft tissue management?
Yeah, I think it can definitely be used. I haven't started using it in my practice yet, but yeah, it's starting to become more widespread because of some of the soft tissue healing that it can promote, and so I think we'll start seeing more and more of that, and I'd like to start using it once I see some of the if you can get the same equivalence, to some of the techniques that we're using. So yeah, I'm interested in seeing more of that at the meetings, but I personally don't use it yet.
Right. Well, I mean, a lot of questions came along to talk about the socket grafting, ridge preservation after extraction with the PRF. And there's, through my courses, when we talk about the PRF, there's a mixture between support bone graft or soft tissue grafting or soft tissue enhancement or healing. In the literature, what we know from the PRF that it is effectively getting positive results in soft tissue healing. So in the bone graft, and we're talking about the socket grafting, it's absolutely getting good results because of the support for the coverage or the primary closure over the bone grafting that we're using. So I use it sometimes, not all the time, but it's absolutely a great, good technique to use the PRF or even the IPRF. Great. There was a question coming from Dr. Jones. It's really an interesting question of two sections. How would you decide to plump the attached gingiva either with freeze, the FDBA or the CTG? And she's mentioning probably the dual zone technique. How can you choose in between to go either way? And the other section is how would you decide if you want to support the buccal aspect, the buccal plate, either with bone graft or either with soft tissue grafting, especially in immediate implant cases?
Yeah, great question. So I think the number one that you need is the buccal bone has to be preserved, and that is through both the extraction and the implant placement. So it can't be damaged during the process of the extraction. The implant can't encroach on the buccal bone. There needs to be some kind of gap, and that gap needs to be grafted with some kind of bone graft. And whether it's FDBA or whether it's BioOS, I don't think it makes a difference. I just prefer FDBA. I think it works better. But if you want to add additional tissue, connective tissue graft, I think it's not wrong. And I think in areas where it's a thin, definitely have a thin phenotype or biotype with higher risk of remodeling, kind of like I was showing with those two different, thick or thin biotype classifications, then I think a CTG is recommended.
Absolutely. I just wanted to share this. One of my best slides is always to preserve the soft tissue will lead to preserving the bone and vice versa. So it's both ways. It goes in soft tissue and hard tissue. Another question talking about the thin phenotype, and you mentioned your research at the EU. How do you manipulate or change plans when a patient comes with a thin phenotype?
Change plans.
Yes, how do you approach cases? Like, what's the risk factors? Do you have any considerations? What does it change if you saw a patient come to you with thin phenotype in regards of placing implant, immediate implants, or even some soft tissue root coverage procedures?
That's a great question, because I think if there's thin phenotype and they already have recession, then there might be an ongoing recession component that needs to be addressed. So for example, if there's evidence to say that they're high risk for further recession, and whether that's, a combination of aggressive toothbrushing, or they've noticed that the recession has been getting worse, and things like that, that's going to play into the timing of that implant placement, because the adjacent teeth margins may be also changing over time. So I think kind of comprehensively, you have to make sure that that thin phenotype patient doesn't have other periodontal concerns such as recession that could be ongoing, because you don't want the margins to be changing on the adjacent teeth after you've placed the implant.
Amazing. Yeah, great answer. Thank you, Brian. I have a lot of questions, so we're gonna keep going with. If you doctors have any follow-up for the question, feel free to type it in. I'm following your question up here. I want to mention that Brian is a great musician. He plays the guitar, and he has an professional band also. I follow him, I go to his concerts, and I'm mentioning this because there's a question about how deep is your implant, and the song "How Deep Is Your Love," right? So this is so what does exactly the soft tissue thickness will change in your plan for the depth of the implant? How deep is your implant in general?
So in most of those cases, I was going to post a picture of you at one of those shows, Dr. Yassin, but I couldn't find it.
Well, I'm glad you did that. I'm sure Good, no worries. Thank you.
I have it somewhere. Dr. Safiati's there too. But in general, it's 3 millimeters from the proposed gingival margin, and so that gives you the restorative space that you need to have the proper transition zone in the abutment. Because if it's too deep, then you're going to run into probing depth issues. And so you don't want to build in pocket depth around the implant unnecessarily. And if it's too shallow, your restorative options are going to be compromised, and you potentially, if you have a little bit of bone loss or excess remodeling around that implant, you could be showing threads.
Yeah, absolutely. It's a great, Dr. Brancheau talked a little bit about the connection between the implant, the soft tissue and the implant, and the soft tissue and the tooth, which is different. And I think he used the same photo here as I am. One of the most important thing is to remember the biologic width concept in both teeth and implant, which is because of the difference with the gingival fibers, periodontal fibers around both implants and the teeth. We need to know that probably the biologic width around implant could be a little bit deeper than the biologic width around the teeth. So it's really important through the studies. It's a new topic, came probably in the last 10 years, about the thickness of the soft tissue and how deep is your implant to be placed. And we always prefer to have thicker soft tissue, more keratinized attached gingiva around both implants and teeth. But in general, it will reflect also into how flexible our implant depth would be. So I think we get back to this same concept of preserving or supporting the soft tissue to support the bone. So thank you. Did you do your master's on the phenotype and the study, the research, right?
Oh no, it was on grafting dehiscences at the time of placement.
Of the, yeah, yeah.
So it was deficient bone sites,
Yeah.
not immediates.
Yeah. So let me ask you about this. This is related to this topic. You showed a lot of immediate implants and bone grafting in the jumping distance or in the buccal distance. A lot of questions came to the, how do you stabilize this bone particles underneath this healing abutment? Some of the cases you used solid abutments, not really custom healing abutment. So what's your technique to stabilize those bone particles underneath the healing abutment?
So the technique is they have to be kind of sticky with the blood clot. So essentially it's not like packing amalgam, it's not that much pressure, but it's enough to where it can't be too loose, otherwise it's going to fall out. So it has to be enough pressure. I mean, you don't want to push on the implant either, but enough pressure to coalesce so that it's part of the blood clot, and then adapting or making sure that healing abutment is in a way kind of trapping it in. Mm-hmm. And then you can furthermore, you can add whether you want to do a provisional crown or a custom healing abutment, or if you want to just do an Essex or a TRPD that they can wear that will kind of additionally help it stabilize. It doesn't really need much time for it to get secure, and then make sure they're not, drinking through straws and doing anything else that could potentially loosen that graft. Mm-hmm. So yeah, the post-op instructions are also really important, just making sure they know how to care for it.
Perfect. Yes. And, we had this discussion last week, a couple of weeks ago, me and Dr. Katafuchi, when we talked about immediate implant placement. One of the most important concept with immediate implant is to be able to support the soft tissue and preserve the soft tissue itself. And you can do this with the custom healing abutment that we discussed in details how to do it, and Dr. Brancheau touched base with it as well. Related to this topic, Brian, what do you do if you have a big fenestration in the buccal plate in the immediate implant cases? It's a huge question, of course. We covered this a couple of weeks ago, but it's also it's important to revisit this, if you don't mind.
Yeah, that's a great question. So, I was showing those anterior cases. I'd never like to flap those. If I'm worried about a big fenestration or something like that in the anterior, I'm probably not going to do the immediate implant. If it's more posterior and there's less aesthetic risk, then I might flap that and take a look at it and do the membrane and the grafting accordingly. Or you can show you can do flaps like Dr. Katafuchi was doing, where he's not actually lifting the papilla, so it's kind of a trapezoidal flap, or something coming from more apical. So that can be done, but typically I'm doing it where I'm sliding the membrane up the surface and I'm feeling where the buccal wall is, and I don't actually have to see it. I'd rather do that than open it all the way up. But for posterior cases, yeah, that can be done a little more readily so that you can access it better.
I totally agree. And immediate implant placement, especially in the aesthetic zone, we have a lot of measures. The first step to do immediate implant, or to try an attempt for an immediate implant, as we always say, is to do a good diagnosis. Dr. Brancheau showed the cross-sectional sagittal cuts with the CT scan before doing the extraction, which is really important in immediate implant cases to know exactly what's the classification for the root positioning inside the alveolar bone. So you should be able to have an idea about how, if the case is an indication for immediate implant ahead of time. And of course, we should be ready to change plans during the surgery if we were not able to preserve the socket walls, or if we lost any of the bony or soft tissue around the socket area. Great, thank you, Dr. Brancheau. Another question talking about non-resorbable membranes. You showed several cases using the PTFE membranes. The first question is, do you use it in the anterior area, or do you strictly use it only in the posterior?
I love those membranes. They're really predictable for posterior areas. I've tried a couple in the anterior and I didn't like it.
Yes, yeah.
Yeah, I don't, it's because they're designed to be exposed. And so you're kind of leaving a little bit of that, that the formation of that gingiva when you remove it to chance. And so I think it doesn't turn out quite as well. I don't know. I don't know what your
100% agree.
experience is, but
yeah, I am on the same page. The thing is, when you do this non-resorbable membranes, it's mainly will lead the epithelialization to go underneath the membrane, which will lead into 2 layers of different epithelium, which is not too aesthetic in the front area. And plus, we don't have a lot of support to the adjacent papillae, which will make it a little bit challenging for the collapse of the soft tissue. So it looks like most of our colleagues, they use it for the posterior area and avoid the anterior area. The other question regarding the non-resorbable membranes is how deep do you tuck your non-resorbable membrane into the buccal and palatal lingual flap?
yeah, great question. So yeah, that's kind of the purpose of that access flap is just getting enough of a pouch to put the membrane into. And so just as much as you need, I go a few millimeters just to make sure it's secure. So it won't come out.
There was some papers actually published several years ago about suturing this PTFE into the buccal and the lingual flaps. It's a little bit more complicated. It complicates things if you want to stabilize this or suture it. And the whole thing is to make it easy and straightforward. In 3 weeks, when we come back to remove this non-resorbable membrane, is gonna just pop up really easily without even anesthetic. So having more suturing to stabilize this is unnecessary. So as Brian said, just a couple of millimeters into the buccal and lingual flap will stabilize the membrane really nicely. A question about doing soft tissue, connective tissue graft into the buccal aspect of immediate implant placement. You showed a couple of cases, and looks like we are on the same page, trying to avoid as much, avoid flaps, avoid vertical cuts as much as we can, especially in the aesthetic zone. The question was, do you attempt to do partial thickness in your tunneling in the pouch, or do you try to do full thickness flap? What's your preference?
Sorry, I was answering one of these other questions.
Yes. I'm asking about the pouch and the immediate implant placement. There was a question about this pouch, the tunneling that you use. Do you attempt to do partial thickness flap, or do you go with the full thickness flap?
Oh, to put in a connective tissue graft?
Correct.
I would go full thickness on that.
Yeah.
Because there's with the partial, there's too much risk of damaging
perforation.
Yeah.
Yeah, absolutely. I answered this question in typing, and it was the same answer, as if we graduated from the same institution, Brian.
I
Huh?
know, but how does
So
that
it,
happen?
so mainly yes. So it's a very high risk to. With partial thickness, you need a lot of skills to do this, even if it was direct flap. It will be so challenging to do partial thickness with blind technique like tunneling, with high risk of perforation. So it's easier and safer to go with full thickness, better than having a blood supply problem down the line. Couple of last questions here. What's your preference for temporization, especially in the aesthetic zone?
So what I see most commonly is TRPDs or an Essex retainer, and those, and that's just the most common thing I see, because a lot of times you're not able to get an immediate temporary crown on there. Although I think dentistry overall is moving towards that, being able to make nice temporary crowns that could be inserted right away, and have the patient not function on it. And so I think that's where it's going, and we'll start to see less and less of the TRPDs and the Essex retainers. Was that kind of the question, or that you're talking more about the healing abutment?
No, it is. It was about the preference about the Essex or
Oh,
RPD
okay.
or, yeah.
Yeah. So I like the ridge lap TRPD, probably the best, and then the Ethics would be number two. Whatever the patient prefers, kind of have a conversation with them, and see which one they're going to, so they know the differences, so they know kind of what they're getting into ahead of time, because you don't want to have them deliver an Essex and they didn't know that it was a clear plastic tray that's covering all the teeth, because if they, whatever they need for work or for their job, if they're speaking a lot and things like that. So I just kind of have that conversation about those temporary options with them and figure out which one's going to work best.
Yeah, absolutely. I personally, I try to go with some teeth-supported temporary, a removable temporary, provisional restoration. This is why I prefer an Essex, especially at the very beginning, directly after the surgery, because simply we will get forces-free area in the surgical area, and down the line we can upgrade to RPD or any other restoration there. There was a couple of questions, Brian, about the minimally traumatic system that we're using, the Benex one. So do you have any comments about the Benex?
Comments about the Benex?
Yes, yeah, there was like a lot of questions about the name, about
Oh,
how practical it is,
I love
how, yeah, is it?
I can't work without it. No, it saves me in all kinds of situations, and so it's just a great tool to have when you're not able to grab a hold of that root. I think you guys showed a couple different forcep options for grabbing onto roots, but there's situations where you don't have any purchase, and so rather than you can go in and section those teeth internally, that's acceptable too, but just having that tool in your arsenal for me is super helpful, because then it works a lot of the time, and if it doesn't work, then likely it's already splitting the root for you, and you haven't done any bone removal or flaps.
Yes, it's a good system. Do you use it for any posterior cases?
I have. I've used it in situations where there's root remnants, root tips, that I can't get to. And then I will use it for just removing the apical part of the root.
Mhm. Yeah. Yeah, I think
Still there, Dr. Yassin?
You may have lost him, Brian.
Oh, okay.
Yeah, it looks like he's frozen up, isn't it?
Yeah.
Yeah.
He's very, very good at playing possum. Well, thank you very much for doing this today. I'm going to stop sharing my screen. I'm just going to double check that the Q&A here and help you out with that. And you can see the Q&A too, can you not, on your
Yeah.
side? Okay.
Yeah, I've been answering a couple questions here.
Okay, let's let's look at that top one. For patients needing extraction but uncertain, non-committal about their restoration plan, what is the lowest cost, highest value socket preservation technique?
Well, if they don't want to do any grafting whatsoever and they just want to, you know, there's just patients that are not sure or they can't afford it, and sometimes that's the option. So in that case, you just have to preserve as much bone as you can and remove the tooth without causing trauma as much as possible, and then get the clot to form and let it heal to its own devices. The membrane, you know, that non-resorbable membrane isn't really that expensive, and so I think that technique is a fairly good value, you know, for what you're getting. The other option you could do is, if you don't want to use any materials whatsoever, is do a bone graft only and just charge for the bone graft. And then you can put a socket seal over the top with potentially a connective tissue graft, because, you know, that's their own tissue. It doesn't cost anything. You could, you know, not even charge them for that, but just let them know, hey, this is going to be a little bit more uncomfortable because it's a separate surgical, you know, donor site. But if they're okay with that, that could be an option.
Well, thank you so much, Dr. Brancheau, for all this great lecture. I think we covered almost all the questions and answers. Feel free, doctors, if you have any questions, forward this to me or Dr. Brian Brancheau as well. We are more than happy to answer questions. Reminder that we have this full year program, Clinical Implantology from A to Z at the Washington Academy of General Dentistry. We have a lot of guest speakers, a lot of great colleagues lecturing there and helping with this program. It's a live surgery and hands-on program. It's going right now with the pandemic going on. We changed the program into online, so you
Lost him again, Tim.
Okay. Oh, that's too bad. Boy, you know, we've been very lucky with all the webinars that we've done to not lose as many people. Well, let's take a look again at the Q&A. I'm just going to leave my slide up here. For those of you that are interested in more CE, this Friday, Dr. Yassin is going to be talking about full arch solutions in implant dentistry, treatment planning, restorative and surgical approaches. That's 8 hours of CE credit. The tuition for that is $250. The QR code is on your screen right there. I'll leave that up, and let's see if, oh, I guess I'm not leaving it up. We will put that back up. So for those of you that have enjoyed Dr. Yassin and in his Implant Study Club webinars, you will want to be sure to register for this one. The previous webinars are on YouTube at Academy of General Dentistry. Those should all be there, the previous 4 of them. You'll have to just kind of look around who the guest was at during each webinar. And I think we have those all up. Dr. Yassin, are you back?
Yes, I'm here. Can
All
you see
right.
me, hear me? Yes.
We can see and we can hear you.
Perfect. Yes. Well, I mean, as you mentioned, we've been so lucky, even with the full day seminars so far, but good. We're doing so good. This Friday will be Full Arch Solutions, part of this clinical implantology from A to Z. I hope you guys enjoyed this Implant Study Club series. This was the part 5. Thank you so much, Dr. Brancheau, for joining us today. It was great to have you. If anybody has any question, feel free to reach out to me or Dr. Brancheau. As Dr. Hess mentioned, all the webinars are available on the YouTube. So, so go ahead and take a look at them. Yeah, that's it. I will see you this Friday if you want to join us for this Full Arch. It's going to be a full day of talking about full arch, both surgically and in the prosthetic way. And we will continue our clinical implantology from A to Z back in June. We are opening our registration for 2020, 2021. For coming year, we'll start in September. So if you have any questions, don't hesitate to contact us at the Washington Academy of General Dentistry. Thank you so much, Dr. Hess.
Thanks.
You're welcome. There's somebody typed a question in the chat. Can that implant A to Z be recorded for later review if I sign up? I have to work this Friday. Dr. Doan, yeah, we'll see what we can do for that. No promises, but we will record that. And if we have the ability to make that CE on demand in the future, you'll be the first to know. We're going to work hard at updating our website at the Washington Academy of General Dentistry so that we can put on-demand CE there for us. We know that once we get back working, we're not going to have the ability to spend the days doing this stuff. And so to be able to do it during lunch hours and breaks and evenings. So we're working hard towards that. Just a reminder, this is the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. We'd like to thank all our presenters. Thank you, Dr. Yassin. I think
Pleasure.
that 5 implant study clubs, and then you did another. So did you do 6 webinars for us?
We did 6 webinars. Yes, we did.
Wow. Thank you very much. We appreciate that. That is above and beyond. Hey, for any young dentists out there, we have our Crown Preparation 101 course in Saturday, August 15th. It's designed to take you from seating the patient right through build-up preparation, provisional, and releasing that patient. And it's actually a course that's designed more on the patient management side rather than just strictly how to prep teeth. Yes, we go through how to prep teeth. We go through traditional impressions and how to use digital scanning. So that's a good one for anybody out there that's got a young associate. It's interesting. I'm watching it click by the slides on my screen here, but apparently it's not moving on your side. We'd like to thank Comet USA for their support, Patterson Dental. We'd like to thank the Canadian Academy of Restorative Dentistry and Prosthodontics. And your CE credit is coming from the University of Washington School of Dentistry. Your CE credit will appear in your email box within the next 2 or 3 days. There'll be a PDF that you can put your name on, and just simply save that for your records just in case something goes wrong down the road and those CE credits go missing. For those of you that are AGD members, we will submit your credits directly to the Academy of General Dentistry. You do not have to do that. Those will show up on your transcript within the next 2 to 4 weeks. On behalf of the Washington Academy of General Dentistry, we would like to thank you, everybody that's joined us. We'd like to thank you, our speaker, Dr. Brancheau, today for being a guest. We appreciate you spending the time. I'd like to thank our panelist, Dr. Gary Hayamoto, for running the chat, and like to thank our executive director, Dr. Valerie Bartoli,
He's a doctor.
for all your hard work. We've tapped into you pretty strongly over these weeks. We appreciate it.
Thank
Dr.
you,
Yassin?
Dr. Hess.
Thanks, Dr. Hess.
You can address me by Dr. Bartoli. Thank you.
Boss Bartoli.
Yeah.
Thank you, Brian. I appreciate your help. I know
Thanks,
it's
Dr. Yassin. Good seeing you.
amazing. Good to see you. Thank you so much, everybody, and we'll see you on Friday.
All righty.